Welcome everyone to Public Health Musings. I'm your host, Dr. Caroline Kingori, a faculty member at Ohio University, and I'm so glad you are able to join us today. I have an amazing treat this morning, and the best part is that it's a new year, and we are going to have a list of really amazing guests coming onto the show. And just to introduce our guest today, this is my friend. Also, she is my former dissertation committee member, Dr. Enbal Shacham. And I have just followed her work over the years, and I'm really fascinated by her energy and the things that she gets to do. And she happens to be one of my greatest models. And so Dr. Shacham is at the St. Louis University College for Public Health and Social Justice. She's currently an Associate Dean for Research and also an Acting Director of Strategic Initiatives for the Taylor Geospatial Institute, and also a professor in Behavioral Science and Health Education. She has a PhD in Health Behavior from Indiana University, which is also my alma mater. And she also has an MPE from Washington University in St. Louis, an MED in Health Promotion and Behavior, Public Health, University of Georgia, and a BA in Psychology from Rutgers University. She teaches courses in primary data collection, global health, community assessment, among others. Her research interests are in infectious and chronic disease, predictive spatial modeling, community and geospatial health determinants, and she'll tell us more about that. Examining clinical practice to improve health outcomes, the intersection of public health and private organizations to improve public health, as well as sexual health, sexual transmitted infections, and HIV. She is well published. And so if you want to know more about her research, you can always find her on ResearchGate or on Google Scholar. And she's engaged with various professional organizations. Her community work and service, again, she focuses on working with public and private organizations and looking at geographic determinants of community health. So join me in welcoming Dr. Enbal Shacham to the show. Yay!
Thank you so much for having me, inviting me to this great podcast you've started.
Awesome.
Now.
I know, right? I started this in 2020 on a whim, and I'm so happy that it has finally happened. So tell us a bit about yourself. What's your story, Dr. Shacham? How did you get to this place and doing all these amazing things you're doing so that folks can be encouraged and also just understand how diverse and vast the public health field is?
Yeah, definitely. I'd love to. I think one of the funny thoughts I have is my journey feels like it was completely unplanned. So I think I consistently get lucky in times, and I know that it is not just luck. I don't actually believe in luck, really, but sometimes I look at people and say, you just got lucky. But for me, it was very interesting in my path, I think. I worked at, so let me go back to the way beginning. Let's start there. I was born in Israel, and my family came to the United States when I was about 3. So I grew up in the United States. I grew up in New Jersey, and I was the youngest of 3, and so I'm the most American, we'll say. And what that translates into is I ended up going to college here in the States. I didn't have much mentorship of how this is done. I didn't understand what kinds of things and supports that people had, and that hidden curriculum of universities that we can talk about now that we're just starting to talk about. I didn't know any of it, and so I went to Rutgers University, again, lucky. I applied to a bunch of schools. I didn't know how to pick them. One of my friends was going there, and I visited with her, and that was enough for me. And so I went to Rutgers University. I wanted to be a clinical psychologist, but again, not did I look it up. We didn't really have Google at the time. I'm going to age myself. And we didn't really, I was like, I want to be a clinical psychologist. I want to be an adolescent therapist. I had experienced a friend in high school who died by suicide. And I said, I understand adolescence in ways that adults don't. And I could have helped him. Now, truly, I probably couldn't have. And I wish I could have, right? And so I went to my bachelor's in psychology and a certificate in criminology. And what I ended up with was a degree in psychology. And then what do you do with it? You don't get to do lots of things and be a therapist with a bachelor's in psychology, thankfully, right? Honestly, I didn't have those skills as I graduated. And I worked at I got lucky, and one of my friend's fathers hired me for what was a temporary position. And I ended up working there for 2 years at a computer consulting firm, learned skills that I didn't have. And then I decided it was time to go back to school. So then I applied to schools for a master's in social work because I realized, hey, that's a pathway to be a licensed clinical social worker. Well, then I had one program that was interesting. Now, I didn't know what public health was. I did some volunteer work with the Children's AIDS Network in New Jersey when I was at Rutgers University. And then I didn't know what I was doing. So I applied to this one program that was NEAT. NEAT is what I said. I was like, it was health promotion and behavior. And I was like, I think I like that. And I think that I could, if I go to this program and I graduate from it, I could do youth prevention for HIV prevention for kids. And I was like, okay, I'll try that. So I applied there too, but I decided I was going to go to University of Texas at Austin, do my social work degree. And then that Monday, I decided on Friday. And then that Monday, I got a call from the graduate coordinator at University of Georgia. And he was like, hey, do you want a teaching assistantship? And I'm like, I don't know what that means. What does that mean? And he's like, well, we'll pay for you to go to school. We'll give you a monthly stipend. I was like, I've never taught before. He said, that's fine. You don't have to teach this first semester. And so I went. That was it. Blindly driving from New Jersey to Georgia. That was culturally changing. And it was the shift I needed. I don't think I thought through exactly. But I wanted a Southern experience, which was just really strange for me, honestly, because I grew up in New Jersey. Everything I knew was New Jersey and Israel, like not much in between. New York City, New Jersey, and Israel. And so I did that. And I got to University of Georgia. I remember that first semester was like the most, it was the most motivating and calling to me that I've ever had in school. It was the time I realized that whatever this public health thing is, I love it and I want to do it and I want to figure out what to do and what does that look like. I spent a lot of time thinking about sexual health in that space and HIV prevention, STD prevention among youth. And so when I graduated from University of Georgia, I worked at Aid Atlanta in Atlanta. I moved from Athens, Georgia to Atlanta, Georgia, and then worked there for a while. And then got to run programs for youth in the city of Atlanta to try to prevent substance use and STIs and HIV. So it was exactly what I planned, but I sort of only half planned it. And so that was phenomenal. It was an amazing experience. I look back at the time that I had in Georgia as a really where I grew up. I think so often we grow up in places and then you become a person of who you are in that space. And I was able to do that there. So I look back fondly. I also was able to work at the CDC after Aid Atlanta, and the CDC was working on a youth media campaign to get kids more physically active. And that was really fun. So it was called the Verb campaign, and I was on the evaluation team. I helped develop or guide the development of research or messages. So how do we get these messages to be motivating for children and for their parents to be more physically active? It was successful, and then our funding was cut. So there was that. I did at that time. It really is about who you know and your networks. My old colleague that I was getting when I was getting my master's at University of Georgia, he was getting his PhD. He had moved and gotten a position at Indiana University. So he was an assistant professor. Michael Reese, who was my mentor, recruited me to Indiana University. So I went. So again, not a big plan, but I knew that I had grown out of my position at CDC. I'd grown out of my position at Aid Atlanta, and I wanted to do more. And I wanted to be able to guide the decision making that was occurring. So I had, in my mind, thought that I'd go back to CDC. CDC is probably the most academic setting I could imagine that wasn't an academic system. So I appreciated how they use data to make decisions, and that was a really fun environment, really enriching. So I went to Indiana University primarily because I had the chance that there might be a chance that I could do my dissertation work in Kenya. And I was like, well, I will go. That was the risk I took. And I was like, what's there to lose? Just some years in my life. And then maybe the chance to get to go to Kenya and do work there. And that is exactly what I did. And that was a tremendous experience thinking about mental health and symptoms that people expressed when they came to support groups in Kenya. And this was similar to some of the work I was doing in Atlanta in my internship and my master's. So I was able to really elevate it as a research question, an important research question, particularly then when we were still trying to understand how and what was interrupting medication adherence. So this was among a sample of people who were seeking care for their HIV, but also presenting for care at support groups. And those were organically grown. It was an amazing experience, understanding how to express mental health symptoms, and then thinking about the relationship of mental health symptoms and medication adherence. And I think that piece really has driven much of the work that I continue to do, understanding what challenges our mental health, what are the other social and environmental factors that interrupt our care, our best care. Ultimately, Kenya gave me this amazing experience that was really enlightening. It's an amazing, thinking back to that cultural experience of me showing up and saying, I don't know what I'm going to do, but we'll figure this out, was tremendous. It's exactly what I wanted to do and what I needed to be doing. So I didn't know that when I planned it or ended up in Indiana. And then I graduated and moved to St. Louis for a postdoc. I was able to be a postdoc fellow at Washington University in St. Louis in their School of Medicine, in their Department of Psychiatry. So I didn't know much about the medicine, like medical school environment. I understood it through the lens of my experience at Indiana University, where they partnered with Moy University and did medical student exchanges. I understood that. I saw it. I could understand it in Kenya. And then I didn't know what does a PhD do in a medical school? They do a lot of research. And we can't, most of the time we don't offer clinical services, so I can't complement my salary recovery basically in that way. So I had to dive into research and get on a lot of research grants. So I had my postdoc opportunity. It was I was trained in psychiatric epidemiology and really thinking about the measurement of psychiatric illnesses. And that was, again, not what I planned, and tremendously important for the next step of my research and how I could use it in the future. I didn't know that was going to work, but it did, and it was phenomenal. And when I think back to that time, it was really hard. It was challenging. I was able to, start in a new city, figure out how to grow research partnerships. I was really lucky, and I found an HIV clinic director that wanted to do research but didn't have enough time. So we partnered on so many papers and research projects together that we had just a great working relationship, and that was awesome and really motivating for much of my career, honestly. And that shifted my trajectory to really focus on HIV. I know that I had been doing a lot of work in HIV before, but I hadn't thought of myself as solely an HIV researcher. Now, this is where things slightly shifted. So I'm research faculty at Washington University in St. Louis. I'm working on HIV-related research. When you go to a medical school, they ask you, what's your disease? What do you study? And I was in public health. In my mind, it was, I think about sexual health broadly. What is your disease? So I focused on HIV. Because most of the time I got into HIV particularly because it's not fair. That's where I got stuck. And I remember being an undergrad at Rutgers University, and I said, wait a minute, the people over here are getting infected with HIV, but the people over here are doing the same things and not getting infected in HIV. And then I found the language about inequity, and I said, oh, not fair means this, to me, inequity is driven by our systems and how the systems are set up and not really fair. And so it was about sexual networks. It was about the mental health challenges of coming up and out as gay or homosexual or bisexual or just questioning at the time, so in those systems of those networks, it wasn't fair. Like, to me, it just didn't make sense. Like, that outcome should be safer. That outcome should be less life-changing because everybody else got to do it. And those outcomes didn't have the same long-term impact. And so I think about that. I still do. I think HIV is a perfect example of inequity among who gets infected, how do they seek care and get care. That's inequitable as well. And then who continues to have challenges getting medication or adhering to their medication. When your life is chaotic, it's really hard to remember and prioritize taking medicine every day. If you don't have stable housing, if you have significant psychiatric illnesses, those are real continued challenges. And so I still think about that. And I think one of the projects that we came and developed early on was looking at locations and neighborhood conditions of people living with HIV. And so I identified among the people who were seeking care and getting care at the clinic I was working with, they still had different outcomes. And so what are those challenges? We were able to identify all these other medication adherent challenges and barriers, but what about your living conditions? And so what we were able to identify, even when you had access to healthcare, and in the United States, we have Ryan White Care funds that provide those wraparound services, provide transportation, and depending on your region, we have services that are delivered to people with HIV. So the needs should be reduced, but we still had inequity in outcomes because people who lived in poorer neighborhoods were less likely to adhere to their care. And I said, it's about our home environments. It's about where I live, work, and play. It isn't about the fact that I can get to the clinic once every 4 months. That's part of it. It's part of the solution, but it's not alone. And so I think about that, and I think about that transition to geospatial health. And that's what really launched me into, well, what can I do? What can we understand better? And what policies can we try to build and improve upon so that people can have more equitable environments and ultimately a better health outcomes.
That's a fascinating story. I love it. I love it. It's a good story because I think it really humanizes what you did in terms of our paths are not always set. Like we go through, like you started with psychology, and then I was like, whoa, what is this prevention, right? And then all of a sudden it's public health, and that was it. That was the journey. It made so much more sense, and it's so all encompassing and inclusive of all these different disciplines, but also recognizes, like you said, health is where we live, work, play, all those things. And the burden of change is not on the individual, So you talked about this geospatial, and I wanted you to just go into a little bit more detail about that. And, you also You focus on spatial modeling, geospatial health determinants. What does all that entail?
Right. So a couple things. Well, I moved to St. Louis University after about 5 years of working at Washington University. I was offered a tenure track position that I couldn't resist, and it was a great opportunity. Much of the work around understanding the physical environmental factors actually happened at St. Louis University. There's a lot of measurement of sidewalk audits. We had grocery store audits, and understanding that they really contributed to the foundational work around geospatial health. And so I was like, this seems like the right next step for me to work with these colleagues. I started here as assistant professor, and I continued to work with Washington University. St. Louis is a small city. We can work together. And really what I was able to do is say, geospatial is growing. Some of my frustration around data and understanding people about that live, work, and play was the lack of real-time data. And if we collected real-time data, we could know more. And so that was part of the development of my understanding. So I was able to secure a grant that was focused about measurement of real-time alcohol use and mood, and its relationship to medication adherence for people living with HIV. So what we were able to do in that study, though, was to actually ask, and this is early on in technology, we handed out smartphones with an app that we developed. We handed out smartwatches, so we could start tracking activity. And we also had a MEMS cap, which is a date and time stamp every time somebody opens their medication. So we were able to really connect all of those pieces of data to say, how are people living, working, and playing in their spaces and throughout their home life? So we asked people to do this for 3 weeks, I believe. And we were able to see where they went, how often they were encountering people, alcohol selling establishments, for example. And what we were able to see were the patterns of mood and how they changed over time and throughout the intraday changing was important. And thinking about alcohol use. And one of the things that I think providers may still say is that alcohol is a depressant. Well, no one is depressed while they're using alcohol. So we were able to really track that and say people are getting happier and happier as they are drinking more. Not a surprise for people who do drink. And it doesn't account for the fact that when providers are telling patients, or when parents or when teachers are telling their children, it doesn't, it's an incongruent message, and it makes you lose your value, right? So if I'm telling you it's a depressant, like, well, I feel really good. I think that's one of those important feelings and messages that we have to be able to negotiate. One of the reasons of that study with real-time data collection was the providers at the HIV clinic I was working with. They told me they didn't want to intervene on alcohol use. It's socially acceptable. They have to say all these other things to their patients each time, like make sure you take your medication, don't use drugs other than alcohol. Don't forget to use a condom, and don't forget to tell somebody you have HIV if you're going to have sex with them. So those are a lot of really big messages. So they said, we want a safe amount. Do you have a safe amount that we can understand, and how can we talk to our patients? So that study was able to help me twofold, thinking about how technology can really better help us better understand what we know and what we know when. And how can we then intervene on those things? And so what I think the important piece for me was, these interventions need to be developed and delivered. They're not hard. Now our technology has gotten to a place where we're getting push notifications all the time. We actually turn them off a lot. And so thinking about those push notifications that actually could motivate us. I mean, I have on my activity watch, move, right? Like, I ignore that. too busy to move right now. Or, you think about those things, and we have to figure out how to better harness the data that are being collected and used by others for public health. And that's where I'm focused now. So I think 4 years ago, we developed this small proposal that was an internal grant to our St. Louis University. They asked for big ideas, and they called it a big ideas project. And we're like, I don't know if this is a big idea, but we're collaborating across the university around geospatial science and application. And so what I quickly learned was I know very little about geospatial technology. And the more I know, the more excited I am. There's so much data. These data are available, they're being collected, and we're not using them in a way that is meaningful for public health, healthcare, or really just community understanding. And so we started this Geospatial Institute, and we basically were pulling things together at the time, like programming, growing GIS programs in general, but like, how do we get more students to understand that location awareness? And then we got to the next step, and we got some grants together. And then we got to the next step where we were really built up as this larger grant internal to St. Louis University. It was we were the Geospatial Institute. And then with the last year, we have announced and started in April of 2022, we were able to launch the Taylor Geospatial Institute. So we received a large donation from Andy Taylor, who is the chair of Enterprise Cars, and he believed in our mission. But with that, he wanted us to grow research, application, and the workforce in St. Louis. And what that translates into is that I think this is one of the biggest benefits and challenges, is that our research is collaborative across 8 institutions. So St. Louis University is one of them, but we also work with 7 other institutions, 6 being universities, 1 being a research center. And so thinking about the different skill sets and interests that people have and bringing them together, and how do we do bigger, better, and ultimately answer or respond to our big grand challenges, thinking about climate change and to me, health and food security, water security. Broadly, we're thinking about global geospatial health as well. So it's been a whirlwind of understanding, thinking about how we can use the data from our wrists to the satellites and everything in between to better understand and intervene on where and when.
Wow. I just love it. I like how you just fall into this amazing things and you continue to become so interesting. Just like when I first met you. So I really want to talk a little bit more about that. So I know we talked about how, availability of services. We talked about matters of equality and equity. So I know in 2016, you published a paper looking at geographic variation in condom availability and accessibility. So yes, you measured this using decoding, mapping, spatial analysis. That sounds really complex. So tell us more about the use of decoding and mapping, and how do you bring all these things together to analyze health disparities? I just love it. Technology for me is fantastic. Yeah.
I think because we use it all, we've made it, technology is so easy for people to use now. So we use it all the time, but we don't use it for data for good, and that greater good is important to me. I think one of the challenges that we are presented with is, how do we partner these data sets together, and how do we know what we know, right? So I had a graduate research assistant that came to me and said, "Hi, I'm really interested in chronic disease prevention." And I was like, "I'm going to need you to work on sexual health. And we're going to do a study on condom availability." And she looked at me and she's like, "Okay." She's still one of my favorites, thinking about how she was able to just jump in. And what we did at the time, we used one of those I think there's a business data set, and just started calling up potential condom selling establishments in St. Louis City. And so we were able to use their address and their phone number and call them and ask them about their availability, and if they sold condoms, where did they sell them in the store? Out in the open? How much were they? Thinking about the different measures of access. Those different measures of access were really important when we think about food deserts, and then they transition to food swamps, right? So that idea of food, the quality of food is not great when you have convenience stores, but convenience stores those corner stores and convenience stores tend to be very accessible, right? In my neighborhood, I can go, I can walk a block this way, walk a block that way, and we're still able to get poor quality food, or poor quality, but it's not quality, poor access to condoms. So they would sell singles, right? So you're paying $1.25 for a condom. This was 2015, so I'm guessing it's even more expensive, but nobody wants to spend that money. No one's thinking about doing it that way. And so those are important factors. And what we wanted to know is there a different spatial relationship by neighborhood with condom availability and accessibility? And then ultimately, is that related to sexually transmitted infection rates? So what we were able to identify, is that true? There's condom availability is tricky. There are many stores that sell it, but it's hard to find. And that access encounters many barriers. And some of the barriers are interpersonal. So when you go and ask, there's a whole process that people have to look at you and laugh, and they feel uncomfortable. And there's never, we ground truth 100 of the stores that we had called. So Lauren called 1,270 stores, I think it was. And we went out to 100 of those to just basically make sure that the data were correct, that we collected, and it was consistent, valid, and reliable. And what we were able to identify, that yes, it was true, and everyone was very uncomfortable when we asked those questions. They made jokes about it, and they made us uncomfortable. It is not surprising that people don't want to purchase condoms. So there was that piece. And then there was the other piece of being expensive and hard to find, even when they had them in the stores. And most of the time you want more than one. And so then you have to think about, like, okay, I get a pack of 3, but it costs this much. I get a pack of 12, it costs that much, but I need to go to the right store to get a pack of 12. And so those are significant barriers to STI prevention, I think. And ultimately, I wasn't saying that the condom was the solution. I think I was saying that if we have condoms out and available, we know that there will be a shift in social norms. People like me use it. You walk into a store, it's accepted. And so that was why we did that. And then we took the data and looked at the addresses. So when you take an address, you geocode it, and it gives you a latitude and longitude. And then you map it out. And then you start looking at what are the relationships. So it's really very similar to a traditional biostats question, right? So here's your data, here's your map, or here's the bivariate analysis, or what are these two, what's the relationship of these two variables? And then what's significant? So we wanted to say, okay, this looks like they might be related. It looks like there aren't a lot of places where you could buy condoms here. What does that look like with the relationship of condom availability and sexually transmitted infections? So we looked at gonorrhea and chlamydia together, and then we looked at HIV with location, knowing that the patterns of those infections shift. And so we wanted to see that. So it's really a regression model, and then it's a spatial regression model. That's all it is. So I want you to, people get nervous about those data, and I think it's just the way in which we start talking about it and practice it and experience it. And so we were able to see areas where that concentration was higher, was more significant, and therefore we said, oh, look, these pockets of sexually transmitted infections are higher here, and they have poor accessibility of condoms. And that's an important finding, I think, because it talks to to the notion of what people do in this community.
I think that's really amazing, because often, we think that people are just not going out to get the condoms,
right,
or they don't want to use them. And access is a really critical factor in examining how it impacts behavior change, right?
Yeah.
So shifting to COVID-19, right? You've done all this work. And in 2020, 2021, 2022, you have been publishing extensively and looking at COVID. And I just wanted to find out, how has COVID impacted or informed your research? And then we'll talk about how some of your work has also incorporated spatial analysis with COVID-19.
So COVID-19, I will say that I used to have to explain what geospatial health was, and then COVID-19 happened. And I think that the first dashboard from the intern or the student at Hopkins that was an Esri intern, I mean, that was luck. And we needed that, right? So we really needed that very quick and dirty dashboard that was beautifully done, right? It was exactly what we needed to see at the time. And then I knew right away that if I was going to do anything around spatial health, this is where it is. And I was also intrigued right away. I was concerned about the policies that were being implemented. I was concerned about what we didn't know. We knew so little, and science is so wild, right? Science is wild. We do a terrible job talking about how science changes all the time, and that's good. We want it to change, right? So we want our understanding to change pretty constantly, and it feels very uncomfortable. I always equate it to the understanding of, nutrition, and how, one day we can have egg whites only, and so one day we can eat the whole egg. And it's like the same idea. Science changes. It's okay to eat the egg yolks. Fine. And I think that we didn't do a great job communicating, and we continually should not communicate. I think actually everyone threw their hands up with COVID-19. COVID-19 was an opportunity for me to really promote the idea that non-traditional data sources need to be complementing healthcare and public health sources. Healthcare and public health are going to continue their important data collection and data reporting. That is not to interrupt or any of that, but we can provide some of that non-traditional data that really intervenes and gives a better understanding. One of the most important thoughts, so early on we were mapping where, the concern was, where are people at most risk. So we wanted the older adults, we wanted the chronic diseases, we wanted the comorbidities, and we were identifying these patterns, but we didn't have a lot of COVID-19 infections at the time. So it was, this is going to be a concern here, this is going to be a concern there, and those are important factors. At the same time, we didn't do a great job of saying, how can we dampen the effect of COVID-19 from an urban environment to our rural communities? Our rural communities have been ravaged by lots of lack of resources. The lack of healthcare system availability is pretty important. Local public health agencies are strapped for resources. And ultimately, we could have done better by saying, okay, let's figure out where this is coming and how it's coming, and slow it down. We just want to slow it down. Because we didn't know enough, there was a lot of finger pointing early in the pandemic of, these people are not staying home, or these people are getting infected. Why? And that inequity was already, those disparities were already evident. So that was happening in Black and Brown communities across the country, but especially in St. Louis as well. So I quickly was like, why are people leaving home? Well, they're leaving home because they have jobs that they're not able to stay home and work. That privilege of being able to work from home is a significant privilege. So it was one of those really important things that we were able to identify. So we used anonymized smartphone data to understand geomobility. So where and when people are going places, how long they're spending time there. And then we were able to say, oh, they're going to work. And they're going to work and they're going to be there for this many hours, at least 8 hours or 4 hours. And we were seeing 4 and 8 hour chunks of time where the company we were working with provided these data to help answer some of these questions. So I was able to identify these findings and work with our St. Louis Metropolitan Pandemic Task Force and say, these results are really important. We mapped out where people are going. We mapped out, used census data, overlaid some census data to identify employment type. And so we were able to say healthcare support, food support, manufacturing, all of those three types of jobs were more likely to leave home. People in that neighborhood were more likely to live there, and they were more likely to leave home. So that's why they were the new essential workers, right? And they were required to go to work. Now, I would argue that the next step of that should be, how do we make employee-based health more a priority, right? So how do we protect our employees? How do we make sure that they can stay home when they're sick? Well, we could pay them sick leave. How do we make sure that they can get tested and want to know the results? Because if you can't stay home and have sick leave, why would you want to get tested, right? So there's the lack of motivation of, but not like, I just don't wanna. It was, I can't know I have COVID, because if I have COVID and I know I have COVID, then I can't go to work. And if I don't go to work, I don't get paid. So I think, to me, that was one of the first and most important findings in COVID, that I was able to really complement the work of healthcare and public health agencies to say, look, I can tell you the why. You told us this is a problem. I can tell you why this population or this community is doing, or people who are living in this group of areas are behaving in a way you don't want them to, right?
Wow. I really like the fact that I'm discovering so much through, because it sounded like it was like this thing that was already way up there. When you think about geospatial work and spatial modeling, it just sounds really complex, and it's really highlights again the importance of those social determinants of health. Yeah. That place where people work and play and go to school and all those things, that really impacts how people behave and the extent to which our public health measures become effective. So you also did, looked at geospatial modeling with regard to vaccines, and I think it's the same thing. Why would people want to be tested? Why would people want to be vaccinated when they don't have time to go get those two things, right?
I think so. I think so we looked at lots of different perspectives of vaccines and vaccination uptake. One of the interesting things, with COVID is that the mindset shifted so quickly. And this was several things I think is really important that we take away as public health professionals, is that social norms can change very quickly now. I came up in a time where every researcher said it's hard to change social norms. We are changing them like monthly, honestly, if not sooner. And so it's important to think about, how are we using those shifts for benefiting public health? How do we craft the messages that are motivating and important, and they might shift social norms with some of that? I think one of the challenges was catching the social norm, or getting the vaccines the same time people wanted the vaccines. We didn't have that. And so for some of the population, and I think one of the challenges was particularly, how is it rolled out? One of the important things I think with the Taylor Geospatial Institute is exactly the idea of collaboration. The purpose of the Institute is for research collaboration. And what we are learning quickly is that, what I learned in the pandemic was that you can't do any of this by yourself. And we know that in public health, but often we keep our circles tight. we have our standard people that we work with. We have our epidemiologist, we have our qualitative researcher, we have our biostatistician that we always work with. But what about the others and different silos? So I reached out. I had a colleague tell me about the supply chain guy, and I was like, I don't really understand what you mean, but let's talk a little bit. And so I reached out to the school of business and basically introduced myself to this new colleague and said, hey, I'm doing this type of work. Do you want to work on something together? And it was the first time he basically interviewed me, like, are you a colleague I want to work with? And I thought, this is really important because we don't have that much time in our lives, and we should make sure that it's going to be a productive and joyful relationship. We're doing hard work. We want to make sure that it's fun to work with somebody else. And so that's really driven much of my collaboration. I tell my students all the time, you will have group members or collaborators that you don't love working with, but you still have to work with them. We don't always get our choices, but make sure when you do, you really pick the ones you really like. So he and we realized our languages were so different, and how we spoke of our research, it was so challenging and different. So each state, if we can remember, when we first got the vaccines, each state rolled it out basically about the same, but they were claimed to be different, So the most elderly, nursing homes, our healthcare staff, and our frontline workers were prioritized. And so what we wanted to do was say, can we develop vaccine optimization model that is spatially informed? And so what we were doing was, all of it was population based. Basically, people were deciding where to promote and allocate vaccines to different communities. And we in Missouri had a lot of rural communities just kind of drowning with vaccines because the people didn't want it. They didn't feel like they were needing that vaccination. They also didn't see that much COVID in their communities. So it was really challenging. And what we identified is that if we had different models of this spatial optimization, we used our public health data, and we used our mobility data. So where are there infections? What is the population like? And then who's leaving home the most, basically. And then we applied that to the business modeling of optimization models. And so what we were able to identify is that if we promoted a different kind of dissemination of vaccines, we would have averted more infections and death. And we have, it's a significant amount I would like to avert a whole lot of morbidity, mortality, and, it's a political move also. So figuring out if we can share these data in a business model sort of way, we think we can do that.
I like that. Trying to speak the language, right? Adaptation. Right. So I'm wondering what your thoughts are when you look at all the work that you've done. You've done so much work with stigma, depression, substance use, HIV, sexual health, now COVID. Then there's this geospatial that really makes a lot of sense. I'm like, why are we not all doing that, right?
Yeah.
So right. What are these lessons learned, when you look at the commonality and the interaction and the relationship between all those things? What have you learned, and what do we need to know?
Well, I think what I learned was that I was curious throughout the whole process, right? So being curious is the only reason I jumped into different spaces. And research makes the most sense to me. In the space that I am sitting, I should be doing more of that. To me, it makes sense. I also think that we can answer bigger and more important questions with a whole group of different thought processes, right? So I work with a computer scientist, I work with a earth and atmospheric researcher. They understand things I can't, right? But they can explain it to me in a meaningful way that I can translate that into hopefully a proposal that gets funded and has a bigger impact, right? So part of that is that's the commonality. Like I can anchor it in an individual level understanding, but I also know that we are the combination of all the things around us. So in my hope, one day when I am going to be out of this job, it's going to be because we've created a way and a model for equitable environments, right? I don't know if I'm going to be able to retire on that, but the hope is that we can create these equitable environments where they translate into more choice for people, and those choices can be healthy, right? You don't have to have a gym membership. You don't have to have fruits and vegetables and on your block, but you need to be able to have that access. And you need to know and feel like everybody's doing a version of this. I don't have to have it every day, but I need to have it most of the days. Things like that. I don't know. I think the more I know, the more work I feel like we have to do. Thinking about how climate change is affecting such multiple layers. It's not just flooding, but it's that security of housing and jobs or drought, right? Like if you're a farmer and there's drought, what's your new job? You still need to sustain your livelihood. What can you do? So what does that translate into worldwide? It's starting to be alarming, and thinking about HIV rates and thinking about how are we going to create opportunities for people who no longer have those jobs that they relied on, that food and water security.
Wow.
I don't know. That's a question, but it panics.
It panics. It's some deep questions, because I always wonder if we will ever be out of a job, which is a good thing, but it's also saddening, because while we think issues are getting better, then we discover that there's a pocket of a neighborhood that there's still so much going on that is taking us back many years. We see progress in one place, but then there's no progress in other places, and it's because of that lack of equitable access to healthcare. So when you think about those issues, what are your policy implications for the work you do? You talked about talking to businesses, calling on them, speaking their language. What language would you speak to policymakers right now to help them understand the importance of this geospatial modeling, but also looking at these diseases that are really not going away, right?
No, I think that's right. I think it depends on the health issue. So one of the things that is good and challenging is there's a lot more people talking about what are deemed social determinants of health, but I also think they're the geographic and social determinants of health. So social determinants of health kind of are categorized in census related data, and that we'll have lots of versions of those indices really that had been developed, like the area deprivation index, the social vulnerability index. These indices are great for telling us in general that pocket suffers more from basic needs. Okay, but to me, one of the things I like to do and want to make sure to do is unpack those indices to say, are there levers that we can push and pull to say this is a policy perspective, right? Until we have a universal income, we probably won't be able to achieve all of this. So what are the levers? I can think of a project we did with childhood asthma and looking at the environmental factors that trigger worse asthma cases. And so thinking about public housing, closeness to manufacturing, close proximity to highways were really the three indicators. We know that those contribute to poorer air quality days, more poorer air quality days. Okay, so what can we do about that? You know what we can do? When I work with my environmental engineers, they say, well, if we grew more trees or even shrubs, they would absorb much of the pollutants. And I said, what? Why didn't I know that? I mean, I knew that, but I forgot. right? Like, how do you connect those things? So can we create a policy that says two things for public housing? They need to be farther away from the major roadways, and they need to have lots of greens. We know that green is good for people's mental health and physical health, but now we really understand that air quality can be addressed by increasing trees and green, and that green shrubbery that doesn't have to be as scary, because often people are like, well, I can't plant a tree. It's going to take too many years. And it's the elected officials that want the credit, right? So if you say, here are your shrubs, you can plant shrubs and you get the credit quickly. You could quickly get the credit. That is an investment that probably really, really would improve health quickly. And so that is those levers that I think are really important to unpack. And without collaboration, I wouldn't have thought through that idea.
So I like how you have emphasized the importance of collaboration. And I think public health has helped us understand the importance of bringing different voices. Yeah. And that's the essence of what we do. We can't claim that, oh, I'm a public health person, I know everything, right? You can't say this is my field, because it's such a field that needs and feeds off of the work of other people. The fact that we can work with engineers, we can work with anthropologists and things of that nature, and you have embodied that with your institute. So, tell us a little bit more about your institute and what you do there. And how people can be involved.
Excellent. So thank you for asking that. So the Taylor Geospatial Institute is really a space where we collaborate on research projects, and we are building out our workforce development. So within the first year, we are tasked with research, but knowing that actually most universities that are doing workforce development, we don't call it that, we're just teaching. And so one of the things that we were doing was realizing that there's a lot of overlap or a lot of missed opportunities thus far. So across our institutions, we're growing some of the research projects, but we're also promoting ideas of we have been running this conference with St. Louis University and the National Geospatial Intelligence Agency annually for 4 years. It's called the Geo Resolution Conference. We have this conference, we bring people together, and it's a national conference where we talk about different, last year was about climate change and a broad array of its impact. So it was about migration and food security, water security, and health. And so when we look at those ways to get involved, that would be one easy way to come to that conference or reach out. Another thing would be we have seed projects. So we offer funding opportunities. I think it's twice a year. Again, we just started this last year, and we've had 2 rounds thus far. So we think it's going to be twice a year. And you would partner with one of the partner institutions if you're not affiliated already, to really broaden the impact that we have. We want to conduct research that is interesting and important. We want to conduct not as much incremental science, right? So incremental science has a very important role, but I think the other part is this larger collaboration challenges some of that incremental science. We can learn this much, and that's a very safe way to spend money. But I think what we're able to do is say, we can do more with this because it's not as rigid. And that's what we're hoping for. So seed projects, we have speaker series, and our conferences. We'll be having more conferences, but I don't have those details yet.
Great work. I am so proud of what you've done, and I'm so excited that I get to see all this progress, and I get to call you my friend,
Me too, Caroline, me too.
So one last question as we wind down. This is something that I always ask my guests. What is your most memorable moment in your work or your life to date?
Well, that's hard, right?
It's a lot. So 1 or 2.
I mean, my life, I'd probably say my kids, right? Them being born, probably most memorable. And it should be. They'd be really mad at me if I said anything else. And I think these moments, right? So I remember my first trip to Kenya. And I can remember the smell. of these amazing smells. And I was like, so amazing. And I remember a person saying to me, is this your first time on the continent of Africa? I said, yeah. Can you tell? I think that, I think it was a reminder of how big the world is. And I think that, and how important it is the work we do. It affects so many different people and places, and it's needed.
Indeed. And I think you bring a little bit of that world also in your institute and the work that you're doing and the vast experience that you have in global health and as well as public health. And so glad to see everything that you've achieved to date. And just, it's amazing how you got to work with the CDC and then now you're in academia. And so you're really able to understand that aspect of public health from the policy side, the federal side, but also the academic side and the community health side. And I think that's, you have really embodied and showed us just the importance of being open to where, this journey, this life will take you.
I think that's scary for lots of people,
yes.
Right?
Yes,
yeah,
yes.
I think so.
So if people wanted to get in touch with you, how can they do that?
They should email me, and if I forget to respond to you, it's not because I didn't want to, it's because I forgot. Email me at enbal.shacham@slu.edu. So it's enbal.shacham at slu.edu. It will be great to hear from you. Thank you.
So thank you so much for coming on the show, and I'll try and we wouldn't wait another 2 years.
No.
We tried this in 2020 and we were busy. There was so much going on at that time. And I'm glad that I was able to circle back and, email you again. And thank you so much for, in your busy schedule, availing yourself and chatting with me and just being able to let people know, right, how amazing public health is and how it incorporates all these different fields and people. And so I want to also thank all the listeners and the folks who will be viewing this YouTube video, and to say that we are looking forward to an amazing year and we'll have amazing guests just like you. And so thank you so much for coming on, and thank you to everybody else who gets to listen to this. And please subscribe and send me an email and let me know what you think about the show, and you have any questions or suggestions for guests that I should have on the show. So thank you again, Dr. Shacham. We're so glad that you were able to join us today.
Thank you so much for having me.